therapy and fluids. It's a basic need. What exactly is IV therapy? Well, it's this method of supplying fluids and electrolyte directly into the intravascular fluid compartment, directly into a vein, or in some cases an artery. What are some of the purposes or goal of it? It's basically to correct or prevent fluid and electrolyte disturbances. It can be replacement therapy for fluids or electrolytes, blood. Low in blood, you can get that IV therapy. You'll learn more about that in Nursing 112. And TPN, which is nutrition, and that would go directly into your veins for nutrition. You'll learn more about that in Nursing 112. We also use it to give intravenous drugs, and it's direct access to the vascular system. So vascular access devices. It's a needle attached to a catheter. And it's up a specific gauge, and the gauge is the thickness, and it's inserted into the vein. So the catheter gauge will depend on a lot of factors, since it's the thickness, the size of the vein, and the purpose of the infusion. The vein can be peripheral or central. So you'll learn about central IV lines in Nursing 112. So we're just going to concentrate on the peripheral IVs. So the needle is placed in the vein. It's removed in the catheter. It has a little plastic tubing, and you'll see a video about this. Will remain in the vein. And then you attach the plastic tubing to the fluid, and you infuse it at a rate set by the provider. Principles of IV flow. First one is gravity. Fluid flows from a higher area to a lower area, meaning the higher the bag of fluid is, the faster it's going to go in. Pressure. Fluid flows from higher to lower pressure. Space. The wider the space, the fluid will obviously flow more quickly. And then viscosity, which is the thickness of the fluid. Thicker fluids will flow more slowly than less viscous fluids. So test yourself on these concepts. An IV with an 18 gauge larger cannula or 22 gauge smaller cannula, which will run faster? The 18 gauge will, because it's bigger. Remember, gauges run opposite of what you would think. The higher the number, the smaller the gauge. So D5.5 normal saline or packed blood cells, which one would run faster? D5.5 normal saline, packed blood cells, you know how thick blood is, it's very viscous, so the D5.5 normal saline would run faster. And the last one, an IV hanging 10 inches above the patient or 36 inches. The answer is 36 inches. Remember gravity, the higher the bag is raised, the faster the rate will go in. So review of fluid distribution. We talked about this when we talked about fluids. Intracellular fluids, that's within the cells, and it's present in cells through diffusion, osmosis across the cell membrane. Extracellular fluid, there's two of them, remember that. The intravascular, which is the fluid component in blood vessels, and then extravascular. It's called institutional and transcellular fluid. That would be fluid that's not in a cell and it's just hanging out around the body in the cell, but it's not actually in a cell. So it's extracellular, but it's not in the blood vessel. Again, a review of the fluid lecture, osmosis. Remember water. So it's the movement of water from an area with few electrolytes to an area of more electrolytes. And then diffusion, which equals distribution. And that's the movement of the electrolytes from an area of higher concentration to an area of low concentration. If you need to review these, you can find these in the fluid lecture. Also in the fluid lecture, you'll find osmolarity, which is the concentration of solutes in a liter of IV solution. It means how many solutes are in there. The more solutes, the higher the osmolarity is. Tonicity is how the osmolarity of an IV solution will affect osmosis or diffusion on each side of the blood vessel membrane. Obviously, the more concentration of solutes is going to affect the diffusion or osmosis, and that's called tonicity. There are basically three types of fluids. Isotonic solutions. These are ones that have the same osmolarity as out-of-body fluids. So, they're equal. So the fluids don't move from one space to another. And it's usually to expand your endovascular compartment, make your veins bigger. And you do this because a lot of times either hypotension, you have low blood pressure due to low amount of fluid. So the more fluid that goes into the veins, the higher the blood pressure is going to go up, and you can cure that hypotension. This is just a picture of what it looks like. You see nothing's going through. It's just expanding the intravascular compartment. Then there's hypertonic solutions. It's got a higher osmolarity than plasma. So the plasma fluid level is less than the cells. So the fluid moves out of the cells into the plasma. So if you have edema, you obviously want that fluid out of the cell into the plasma, and that will also expand your blood volume because it'll also make it bigger inside the vein. And a little drawing of that. So it draws fluid and electrolytes into the intravascular compartment. So, and it can dehydrate the intracellular interstitial compartments. So you have to just be careful of that. Then there's hypotonic solution. So there's less solute in the plasma than the intracellular fluid. So the fluid levels is greater than the cells. So the fluid moves into the cells. So if you have cellular dehydration, you're going to want more fluid into the cells. That's when you would use a hypotonic solution. And here's again another nice picture of how the fluid shifts from the intravascular into the intracellular and interstitial compartments. If you just take a look at this little chart here, this is an easy way to remember it. Isotonic, equal, hypotonic, fluid and electrolytes into cells, hypertonic, fluid and electrolytes into the blood. So. These are some of the names and concentrations per liter of fluids. Normal saline is 0.09%, and that's 0.09% sodium. So that's about what's equal in our body. D5W is 5% dextrose in water. Dextrose is glucose, so it's used sometimes when you need extra sugar. Lactated ringers is closest to plasma. It's got a whole bunch of good electrolytes in it, and it can be combined with either of them. So you can have D5W with lactated ringers. So, and there's just samples of variations. You have D5.5, which is half of the normal saline, just half normal saline, and D5 with lactated ringers. It's, it'll be on the order which intravenous solution you use. So we have to always assess as nurses, IV therapy nursing assessment. What do we assess for? Correct solution, obviously. The correct flow rate. The date and time it was hung. and patency of tubing. Patency is the tubing's letting the fluid flow through it. So for an example that if you have a kink tubing, it's not patent, so you're going to want to unkink it. So you just always have to check the patency of the tubing to make sure it is running smoothly. General best practices. You're going to look at the IV insertion site for it, and we're going to go over each of these. Infection, infiltration, phlebitis, and bleeding. And you're going to want to look at the lab values because if you have an infection, your white blood cell count might go up. So, there's lots of different lab values that you can look at that you might need when you're doing IV therapy, depending on what you're giving and what you're giving it for. Interventions, setting up and changing the IV fluid tubing. It's a closed system. It's very important to maintain a septic technique to keep the air out. You don't want air running through your veins. So you can look that up in Skill 42-3 and Hutter and Perry. Patient teaching. You should tell them why they're having the IV, how to care for the site and the equipment. Don't fool around with the buttons. A lot of people want to do that. And then the abnormalities to watch for and when to report them and whom. So we're going to go over some of the complications of IV therapy. So you can use table 42-12 in Hutter and Perry to make notes on the following. Infiltration. It's the inadvertent administration of a non-vesicant solution into the surrounding tissues. And what that means is when you put the IV in, you went through the vein, so the needle is no longer in the vein, it is in the surrounding tissues. So the fluid is flowing into surrounding tissues and not into the intravascular system. So you'll see swelling at the site, blanching, which means when you touch it, it turns white, and the IV flow rate will decrease because, again, it's resistance. You're in the body fluid, in the body compartment, outside of the intravascular compartment. So it's going to be less resistant because the intravascular compartment, the veins, are like a highway. And it's very painful. As you can see from the picture, it's usually a big bump right where the IV site is. You will see infiltrations and you will probably do an infiltration. It's just inevitable when you start IVs. You don't always get it in the vein and you think you do, or sometimes it goes through the vein, especially older people after a little while. When something's infiltrated, what are the interventions? Obviously, you stop the IV immediately and discontinue it. Raise the extremity. Why? Again, fluid goes downward. So you want that fluid, wherever the IV was, in the arm, to go down, or leg. And then you put warm, moist compresses, moist or cold compresses to the area. And that's to prevent further damage to the tissue. Sort of like when you bang yourself, you want to, the swelling of the tissue, and that's basically what infiltration is. And if you're going to start an IV, you need to do it in the other arm. You do it in the left arm, you got to do it in the right arm. Phlebitis, it's the inflammation of a vein, and it's an increased risk for bloodstream infection. So it's pain, warmth at a site, and linear pattern redness, meaning you can see the vein, you can see in that picture how the vein is red, and you can actually trace the vein. As soon as you see that red streak, they call it, you are worried about phlebitis. Again, the interventions are fairly simple. You stop the infusion and discontinue the IV. Start a new IV in the other extremity, and apply warm, moist compress to site and notify provider. Why would we notify the provider? Because there's a chance of a bloodstream infection with phlebitis, and that can be deadly. So we want to let the provider know, and he might want to order some antibiotics, he may not. He may just say, watch it to see if it gets worse. That's usually what they say. And then, but the provider needs to know if phlebitis has occurred. Symptoms of infection, pretty easy. Start getting drainage from the site and purulent drainage. The IV site is red and warm when to touch. And of course, with any infection, you can get a fever. So if you get an infection, obviously you would take the IV out immediately. You culture any drainage if you can. Usually they remove the catheter and save it for the culture, meaning you take the whole plastic end that was in the vein and you put it in a cup to send to the lab for culture to see what kind of bug might be in there, bacteria. You clean it with alcohol, the site. Obviously, you put on a sterile dressing. It's important it's sterile, not just a gauze. Again, you notify the provider. You start a new IV in the other extremity and initiate appropriate wound care. So the provider may say, put this on it or put that on it to prevent infections. You may also order an antibiotic. We're going to talk about circulatory overload. Circulatory overload is basically fluids administered at a faster rate than the circulatory system can handle and transport, filter, and excrete. That means you're putting too much fluid into the circulatory system. So what happens? Just think about it. You're going to get peripheral edema, dyspnea. You look at the jugular vein, you see if that's distended, that's a sign that you have circulatory overload that you will use. The fluid's got to go somewhere, so it goes, into interstitial tissue. Lungs, you start getting crackles in the lungs because the fluid starts building up in there. Increased heart rate because the heart's trying to get rid of that fluid, so it's moving as fast as it can. And of course, elevated blood pressure because you have so much fluid in those veins that it's going to push the blood pressure right up. What do? Reduce the IV rate and you call the provider. Raise the head of bed up. You give O2 and diuretics, which will get rid of some of the fluid if it's ordered. You monitor their vital signs in lab and watch for changes to the IV order. This can be quite an emergency if it's really, really bad. So we give IV medications through the IVs. There are some responsibilities that go along with that. Key points are, you follow your 6 medication rights. You got to check and see if the medication is compatible with the fluid that you're giving. Some medications don't work well with some of the fluids. Some of the medications require central versus peripheral IV line, meaning you can't put some medications into the veins of your arm. You have to have a central vein. And you have to verify in time frame that the med is administered over, meaning, if it's 1 cc, it may have to be administered over a minute. And it's hard to do, but sometimes you have to do it. You don't want to push it too fast. And of course, you're going to watch while you're giving them IV meds because it's a pretty immediate reaction because it's going right into the intravascular system. So you want to look for any adverse reactions to the med, allergies, anything like that, shortness of breath. So those are the nursing responsibilities. High alert medications. There are certain high alert medications. And when you look up in the drug book, it'll say high alert next to it or be red. So those can only be infused with an electronic infusion device. We don't want to take our best judgment. If the fluid rate is correct, we want it on a IVAC, if that's what the electronic infusion device sometimes is called. So you got to monitor certain blood levels with the high alert medications to make sure they're not getting too much. Depending on the drug, you got to look at specific lab values. Heparin, which is a blood thinner, you want to look at the clotting values. You don't want to get the blood too thin and cause bleeding. And insulin, obviously, you look at the blood glucose because you don't want to give them too much insulin or too little insulin. And you'll see next year what effects that have on the body. And so you monitor the medication effects. Is it doing what it's supposed to do? Is it intended effect? And are there any side effects to these high alert medications? One of the most important high alert medications is potassium. So it has to be diluted in the IV solution. And never give it to a syringe directly into a vein. It can burn that vein right out. Potassium burns. It hurts a lot when you have potassium. Even when it's diluted, some patients complain and actually get quite upset because it's so painful. Make sure you mix it thoroughly when you add it to an IV bag. Generally, we don't these days. They're usually pre-mixed for you, but if you have to, make sure it's mixed thoroughly. You don't want high concentration of heparin in one part and none in another part. So you can infuse it at less than 10 milliequivalents an hour through a peripheral IV. And there is a maximum dose, and you should know this maximum dose. It's greater than or less than or equal to 60 milliequivalents per liter. Never want it to go higher than 60. So you got to look for infiltration. Since it burns really fast, it can burn right through the vein. Like I said, it's very painful. Vesicant solution means it can burn the tissue around it, and it can lead to permanent damage. You want to monitor the serum potassium levels, and you need to know this level. It's a very important level in your body. 3.50 to 5.0 milliequivalents per liter. It's the normal potassium. And you never add it to an existing IV infusion. You have to start with a brand new infusion. Potassium can be a lethal drug. If you get too much of it, it can affect your cardiac system and actually give you a heart attack. So, of course, we have documentations. So, and each healthcare facility will have its own specific protocol. So you're going to assess the site, the response to therapy, and any adverse reactions. You're going to document the type of fluid that you're giving with the additives, the flow rate in milliliters per hour, how much is administered over a specific period of time. So usually it's every shift, every 8 hours, how much fluid was administered, the type of the infusion device, what kind of device is being done with, and when the dressing needs to be changed. IV dressings generally need to be changed every 96 hours, but again, it depends on each healthcare facility. So let's test her. The nurse knows that intravenous fluid therapy has been effective for a patient with hypernatremia when A, serum sodium concentration returns to normal, B, systolic and diastolic pressure decreases, C, large amounts of emesis and diarrhea decrease, and D, urine output increases to 150 milliliters an hour. So what is hypernatremia? It's a high sodium level. So the correct answer would be serum sodium concentration. So, which assessment findings should cause a nurse to question administration of a study containing isotonic intravenous fluid? Blood pressure of 102 or 58, dry mucous membranes, or skin turgor, or pityedema. Well, what does sodium do? Sodium makes the extracellular cells retain fluid. So the correct answer is pityedema. Next, a nurse is caring for a patient who is in a hypertensive crisis. His blood pressure is out of control. When the nurse is flushing the patient's peripheral IV, the patient complains of pain. Upon assessment, the nurse notices a red streak that is warmed with a touch. What is the nurse's initial action? Apply warm compress. Initially, you would do you would pull the IV out right away. Then you would apply a warm compress. And this is a typical example of a nursing 112 question, because you want to go for change the IV site, but you're going to first pull the old one out, and that's not an option here. With removing the IV would be a correct first action. Second action would be apply a warm compress before you do anything else. Next one. The patient was admitted for hypovolemia and has intravenous fluid running at 250 milliliters an hour. The patient is complaining of burning at the IV insertion site. When you do your assessment, you don't find any redness, swelling, heat, or coolness. So the nurse suspects that A, IV is infiltrated, B, IV is caused phlebitis, C, fluid is infusing too quickly, or D, patient is allergic to the fluid. And it's a little bit of a tricky one. So the correct answer is patient is allergic to the fluid. Now, if the IV had been infiltrated, you would see the blanching and the bubble and coolness, and that you did not find. Phlebitis, you would see the red streak and heat. Fluid is infusing too quickly. That would be fluid overload, which doesn't go along with the patient complaining of burning at the IV site. But that does happen when a patient is allergic to the fluid. So that's a little bit of a tricky one. A nurse is assessing a patient who is receiving a blood transfusion, finds the patient is anxiously fidgeting in the bed. Patient is afebrile and dyspneic. The nurse accusates crackles in both lung bases and sees jugular vein destruction. The nurse recognizes that the patient is experiencing which transfusion complication? Well, remember what we said about the jugular vein dissection. It's an anaphylactic shock, septicemia, fluid volume overload, or hemolytic reaction. Correct answer is fluid volume overload, getting crackles. So nurse is caring for patient with hyperkalemia. Which body system would be most important for the nurse plan to monitor closely? Gastrointestinal, neurological, cardiac, or respiratory? Correct answer is cardiac. Hypokalemia is high potassium kalemia. So, like we said before, potassium can affect your heart. So you're going to put them on a monitor if they're having hyperkalemia. There may be some respiratory issues too, but cardiac is one you most worry about. Back to 12. Our favorite SATA questions. Which the following assessments would indicate that a patient's IV is infiltrated? A, edema of the extremity near the insertion site. Yes or no? B, skin discolored or bruised in appearance. C, pain and warmth at the insertion site. D, Skin cool to the touch. E, red streak proximal to the insertion site. F, numbness or loss of sensation. And G, palpable venous cord. And the correct answer is edema of the extremity near the insertion site, the skin is cool to the touch, and then you can have numbness or loss of sensation. That if it's really infiltrated, it'll press on the nerves and give you some numbness. So what if your patient exhibited sign of circular overload? What would you do? First, you reduce the IV rate and call the provider. Raise the head of the bed, give O2 if needed, and diuretics if ordered, and monitor vital signs in labs, and watch for IV changes to the IV order. So what if your patient's IV is infiltrated? What would you do? First, like I said, you discontinue the IV, elevate the extremity, apply warm, moist, or cold compress to the area. You know, if it's really bad, you want to put a cold so that the swelling goes down, and you start a new IV in other extremity. So what if your patient shows signs of phlebitis starting at the insertion site? What would you do? Stop the infusion and discontinue the IV line. Start new IV in the other extremity. This is where you apply warm, moist compress to the site, and you must notify the provider. Last but not least, your patient shows signs of an infection at the IV insertion site. What would you do after you take out the IV? Culture any drainage that came from it. You want to clean it then with alcohol. You want to culture before you clean it. You take the catheter and save it for culture. You actually culture the catheter to see what kind of bacteria may be on the catheter. Put a clean, sterile dressing over it. Make sure it's sterile. Of course, call the provider. Start a new IV in the other extremity. And then initiate appropriate wound care if indicated. So that's the end of the IV lecture. Hope things are going well with you all, and good luck.